Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today we're going to be talking about the issues surrounding upper and lower respiratory disorders. So we've got some questions that require prioritization. We've got some questions that require knowing interventions and so forth. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. Mark Klimek is the goat of NCLEX reviews. You can go to clinicreviews.com to sign up for our 21-plus hour NCLEX review, our streaming service, or our small group tutoring. Let's go ahead and get started. I find these questions quite interesting. I think they're very applicable to NCLEX. Which assessment finding in a child with suspected epiglottitis requires the most immediate action? So epiglottitis is upper respiratory, so it's essentially the epiglottis, the back of the throat. Itis is inflammation and infection. So what requires the most immediate action? Barking cough. Okay, barking cough is a symptom of epiglottitis. Drooling and leaning forward. All right, drooling and leaning forward is someone with an impaired airway. This is an impaired airway symptom, so that's a problem. Low-grade fever, that would be a symptom of epiglottitis. Hoarse voice, that would be a symptom of epiglottitis. So the only correct answer here is the unexpected finding, and this is, if you've watched any of my prioritization videos, you know that when you have one patient and they give you a scenario or a disease or a situation that they're in, and then they say, which are you most concerned about, or which requires immediate action, or which should you report to the healthcare provider, you always choose the unexpected finding, and so B is the unexpected finding. A client with COPD has increasing somnolence, so that means they're more difficult to arouse, and a morning ABG where the pH is 7.28, so that's acidosis. The bicarb is 32, that's high. So when the pH is low and the bicarb is high, remember Rome. If you haven't watched my Rome video for ABGs, respiratory opposite metabolic equal. So it's respiratory acidosis. So we have respiratory acidosis here, COPD, but we have a CO2 that's very high in 68. Normal is 35 to 45. And we have a PaO2 that's very low at 58. So normal is 80 or above. So not only are they in respiratory acidosis, they're also in respiratory failure. When you have a CO2 in the 60s or above, and you have a PaO2 in the 60s or below, that's called respiratory failure. They are failing to exchange their gases, okay? So let's see what the options are. Increase O2 to 6 liters per minute. Maybe my concern is that their CO2 is very high and they're a COPD patient, so I'm not crazy about the O2 to 6 liter option. Give a sedative? Absolutely not. They're already somnolent. Start IV fluids. Okay, I don't see how that's really going to help. Evaluate need for non-invasive ventilation. That, my friend, is the right answer. And I want you to know that we prepare to ventilate when the patient is in respiratory failure. So this looks like it's an acid-based question, but actually this is a fairly high-level question where you have to recognize not only are they in respiratory failure, they're in respiratory acidosis, and which is a higher priority, giving them O2 at 6 liters or giving them preparing for non-invasive ventilation. This is respiratory failure is when we decide to intubate the patient. That's how we make the clinical decision to intubate the patient. Now, you may say, but they have COPD and maybe we should try something else first. Maybe we should, but those other options are not there. Like maybe we should try BiPAP. Okay, great. Let's do some BiPAP. But BiPAP is not an option there. The only one that is really appropriate for respiratory failure is D. A client with active TB is being discharged. Which instruction has highest priority? which is best, means best, for preventing transmission. Now, when you get a best question, you can only choose one option. It's not saying what do you do first, it's saying what's best, which means if I can only do one thing, which one thing do I have to do to prevent transmission of TB? So the highest priority to prevent the transmission of TB is to tell them to avoid crowded places for 3 months. 3 months seems like a long time. Usually they don't have to avoid crowded places for that long because the antibiotics do start to work a lot faster than that. The highest priority for preventing transmission of TB is telling a patient to wear a surgical mask at home. No, they don't have to do that. No. The highest priority for preventing transmission for a TB patient is to adhere strictly to the full medication regimen. That is true. One of the biggest risk factors for resistant TB is people who don't finish their full medication regimen, so they feel better, and they're not infectious anymore, and so they stop taking their meds, and then they develop a resistant TB. That's a big problem. So, which really promotes the spread of TB. So they do have to take their full medication regimen, which is usually 6 months, sometimes even a year. The highest priority for preventing the transmission of TB is to use separate utensils from the family. I don't see why. I mean, if you're washing them between family, I don't know why you would have to use separate utensils. That's sort of a not clear answer to me. But let's just say I tell them to use separate utensils from their family. Okay, if I choose that answer, that means I'm not going to teach them to adhere strictly to the full medication regimen. And I have to tell them to strictly adhere to the full medication regimen. I have to do that because we have to make sure the patient doesn't develop a resistant TB, or that's going to be very, very difficult to treat. So C is the correct answer. You are preparing to administer the first dose of IV methylprednisolone, which is a steroid, to an adult in moderate asthma exacerbation. Okay, that's appropriate for asthma exacerbation. Which assessment cues indicate the therapy is working over the next hour? Now, cues is the word they use with NextGen. Like in NextGen case studies, the first question is analyzing cues. Or identifying cues, sorry. The second one is analyzing cues. So I just want you to understand cues is assessment data. That's what the word cues means. So assessment cues is just saying assessment data. Which assessment data indicate the therapy is working? For someone, I just gave them prednisone for asthma. Decreased use of accessory muscles. Well, yeah. Decreased use of accessory muscles means they're getting better. Increased peak expiratory flow rate toward baseline. So increased peak expiratory flow rate. So peak expiratory flow rate is when they blow into their peak expiratory flow rate measurement device. And if they have good ventilation, then they can get it into the green area. It can go red, yellow, or green. And as they constrict more, it gets closer to the red. So as it gets towards baseline, which should be the green area, that's saying they're getting better. So B is an indicator of getting better from asthma. Inspiratory stridor increases. Inspiratory stridor increases. That does not seem like a good thing. So I'm not going to pick that. Improved ability to speak in longer phrases. Well, yeah. So a lot of times if the asthma is bad, they have difficulty speaking more than a few words at a time. So as they have more ventilation, greater ventilation, they can speak in longer phrases. That's true. Decreasing wheeze with increasing silent chest. All right. So this is, I want to make sure you understand this. The more silent the chest, in other words, they come in loud with loud wheezing, and then their wheezes get softer and softer, and you actually cannot even hear air moving through the lungs. That's called a silent chest, when you don't even hear the airflow through the lungs. That's bad. That's not getting better. So if all it said was decreasing wheeze, I'd be like, yeah, probably. But when it says with increasing silent chest, that's bad. I don't want an increasing silent chest. So the indicators of getting better, or the therapy is working, are A, B, and D. The nurse is caring for an adult with obstructive sleep apnea post-op day 1 after a laparoscopic cholecystectomy. So this is just like a patient who comes into the hospital for a procedure and they happen to have sleep apnea. They just happen to, right? And we got to make sure that we manage that while we're helping them recover from surgery. So which intervention is priority for preventing respiratory complications? All right, so and we have to take this into account with the sleep apnea because they told us they have it. So ensuring CPAP is used during sleep is a priority for preventing respiratory complications with sleep apnea. That's true. CPAP is the treatment of choice for obstructive sleep apnea. Administering IV steroids is the priority for preventing respiratory complications with obstructive sleep apnea. No, steroids are not used to treat obstructive sleep apnea. Offering opioid analgesic for comfort is a priority for preventing respiratory complications with obstructive sleep apnea. No, they already have periods of apnea. Apnea means not breathing, and opioid's not going to make that any better. Ambulating once a day is a priority for preventing respiratory complications with obstructive sleep apnea. Well, I don't even like the once a day, but it has nothing to do with sleep apnea. I'd probably want them to ambulate at least 3 times a day. But no, that's not for obstructive sleep apnea. So CPAP is the correct answer in this case. A client with severe bacterial sinusitis, okay, so their sinuses are infected with a bacteria. They're prescribed this antibiotic, amoxicillin clavulanate. Which statement indicates a need for further teaching? So we're looking for the false statement related to starting an antibiotic. If I get diarrhea, I'll stop the antibiotic immediately. All right, well, diarrhea sounds bad, but it's actually a common side effect of antibiotics. So usually what we do is we teach them to manage the diarrhea, like maybe take more fiber, something like that, as opposed to stopping the antibiotic. I mean, they have severe bacterial sinusitis. I don't want them to stop the antibiotic just for diarrhea. Like, we can manage the diarrhea. I'll take all the pills, even if I feel better in a few days. That's a true statement. That's good. Further teaching, we're looking for the false statement if I didn't say that. I can use saline nasal irrigation to help drainage. Sure, they can do that. That's not a problem. I should call if I develop a rash. Absolutely, you should, because that's an allergic reaction. So I need to make sure that they know they need to take their full regimen, and diarrhea is a side effect that we can manage in other ways without stopping the medication. A client with severe epistaxis, which is a nosebleed, is in the ED. Which actions are appropriate initial interventions? Initial. So that's important to remember. So initially, we should lean the client forward and pinch the soft part of the nose. Yes, that's exactly what you do. You don't want that going down their throat and swallowing it. So they lean forward and pinch the bridge of the nose. That's correct. Initially, for nosebleed, we should place the client supine, which is flat on their back, with neck hyperextended. Absolutely not. That's the exact opposite of A. So no, we're not going to do B. C, initially with nosebleed, we're going to apply ice to the bridge of the nose. Yeah, that's fine. That constricts the vessels, so it should help stop the bleeding. That's fine. Initially, we should instruct the patient to avoid blowing the nose for 24 hours after the bleeding stops. Well, yeah, absolutely. Yeah, don't blow your nose. Just could make it worse. Blow out all the clots that got it to stop. That's a good idea. Initially, we should pack both nares tightly with cotton swabs immediately. No, that's not initially. And that's why I was putting initially in front of the answer. So initially we should, because that's what it's asking. So no, we don't do that initially. We do these other things, less invasive things initially. And then if it just won't stop, we can then pack it if we need to. The nurse is triaging 4 clients who should be seen first. So this is who is most likely to experience harm or damage from the symptoms they're having. Influenza client with a fever of 101.3 and myalgias. So this client is considered stable because they're having the symptoms of the disease. So when a client is having the expected symptoms of the disease, they're considered stable. That's why, remember in the previous question where I said, who requires immediate intervention, or which are you most concerned about, or which one should you notify the doctor about? And the answer is the unexpected finding. You can use this here as well. Unexpected means unstable. Expected findings for the disease process are considered stable. COPD client with new confusion, that's unexpected. An SpO2 of 90% on 2 liters. The 90% may or may not be expected, but the new confusion, that's a changing assessment. That's definitely unexpected. So that's a problem. Strep pharyngitis, which is just strep throat, Client with painful swallowing. That's an expected symptom of the disease. Allergic rhinitis, okay, allergies. Client requesting a refill of their intranasal steroid. Obviously, that patient's fine. So the only one that has unexpected findings, new onset. Not only are they unexpected, but they're new onset. It's a changing assessment. Changing assessments worry me as well, is B. A client with spontaneous pneumothorax presents with sudden pleuritic pain and dyspnea. Okay, those are the symptoms of pneumothorax. Which physical exam finding best supports this diagnosis? So they're presenting with some of the symptoms of pneumothorax, but what else could you see that could also support a diagnosis of pneumothorax? Diffuse crackles bilaterally supports a diagnosis of pneumothorax. No, because pneumothorax, you'd have decreased breath sounds. Dullness to percussion on the affective side supports a diagnosis of pneumothorax. Dullness to percussion, like over tissues. So if I percuss over the liver, it's going to be dull. If I percuss over air, it's going to be resonant. Okay, so dullness means there's something in there that I don't expect to hear dullness, honestly, at all over the lungs, whether it's a pneumothorax or not. Hyperresonance to percussion on the affective side. Yeah, hyperresonance. So resonance might be what you expect, but hyperresonance, when it's collapsed, it becomes hyperresonant. That actually does support a diagnosis of pneumothorax. Expiratory wheezes throughout. No, if you've got lung sounds throughout, you don't have a collapsed lung. You have decreased lung sounds over pneumothorax, and then hyperresonance to percussion as well would be appropriate to find. A nurse is about to suction a tracheostomy in a client with copious secretions and decreasing SpO2. Which step is a priority to minimize hypoxemia? So the most important words in any question are the last few words of the question. So the step is a priority, which means best. It means we have to do this to minimize hypoxemia. So it is a priority to suction continuously for 20 seconds to minimize hypoxemia. No, that's too long. It actually promotes hypoxemia. You want to continuously for 10 seconds max. A priority to minimize hypoxemia, you would instill 10 mils of sterile saline before suctioning. No, y'all. Let me squirt some fluid in your lungs. No, apparently we used to do that. I remember when we used to do that. I never understood why we did it. I avoided doing it as much as I could, and I'm glad supposedly it thinned out the secretions. But can you imagine, let's just squirt fluid in your lungs? Like, that's helpful? How is that helpful? That's not helpful, y'all. Give them some IV fluids in their veins to thin secretions, not fluid in their lungs. That's like inhaling some pool water and you'll be better. No. It's a priority to minimize hypoxemia by using the largest catheter available. Well, no, that just cuts off more of the airway. It's a priority to minimize hypoxemia to pre-oxygenate with 100% O2 before each pass. Yes, absolutely. That is what you should do before. Do not be instilling fluid in their lungs. Y'all, don't do it. A client with ARDS, adult respiratory distress, is on mechanical ventilation with high PEEP, positive end expiratory pressure. So what that PEEP, high PEEP, it keeps a certain amount of pressure in the alveoli so they don't collapse, because they're prone to collapse with ARDS. It decreases the overall pressure that has to be exerted. But PEEP, positive end expiratory pressure, is a constant pressure in there, and there are some risks associated with it, especially high PEEP. Like if it's too much pressure, you can overextend the alveoli. The nurse notes sudden hypotension and tracheal deviation to the left. That's bad. I don't like that. Okay, so let's see what we've got here. So what should I do? Increase IV fluids and reassess in 15 minutes. I don't mind the IV fluids because of the hypotension, but it doesn't address the tracheal deviation, and I don't want to wait 15 minutes to reassess. So that doesn't seem good. B, notify provider immediately for needle decompression. Okay, so if you don't know this actually are the symptoms of a tension pneumothorax, that some of that air has been leaking out and it collected in the pleural space. And because of that high PEEP, it's like pushing out through the lungs. And you actually do need to do needle decompression. You need to pull that air out. Decrease PEEP by 5 centimeters of water. What's the priority action? It means I can only do one. So I would want to decrease the PEEP. Well, I probably would, but let's leave it on the list. I know A is not right. Obtain a routine chest x-ray, D. All right, I don't mind getting a chest x-ray, but I don't think I'd want to get a routine chest x-ray. Seems like I'd need a stat chest x-ray. So I'm going to cross that one off the list. And for best questions, you have to look for words like that, because that's one of the ways they make a right answer wrong, is by changing it from stat chest x-ray to routine chest x-ray. Now it's wrong because that's not what you would do. So I'm going to cross off A and D. So now I have to say, well, for a tension pneumothorax, would I want to notify the provider immediately for needle decompression and not decrease PEEP, or do I decrease PEEP and not notify the provider? Well, I have to notify the provider because decreasing PEEP is not going to take care of a tension pneumothorax. The only way to deal with a tension pneumothorax is by having the provider come in and do needle decompression. So I have to do that. That decreasing the PEEP is fine. If they come in and they say, hey, let's decrease the PEEP, we might decrease it by more than that. I don't know how high it is. It doesn't tell me. So I have to notify the provider. All right, so that's the end. Those were some sort of higher level questions. There's a lot of prioritization there. So I hope that was helpful. If you haven't watched sort of the basic prioritization videos, you probably want to do that. And then these kinds of things, I kind of apply the prioritization strategies that I've taught you in some of the other videos. So I hope that's helpful to you. You're going to get a lot of prioritization questions on the NCLEX, so you need to be ready for those. Have a great rest of your day.